Hello, everyone, and welcome to the next installment of Risfeld Neurology Education, a not for profit project exploring all areas of clinical neurology. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. This is the first episode in the Epilepsy and Seizures series, and it's going to be focusing on seizure definition and classification. And before we get into it, a legal disclaimer: the content in this episode and in the Risfeld Neurology Education Project as a whole is for educational purposes only. So, what is a seizure? Well, pathophysiologically, it's an inappropriate and excessively synchronous repetitive depolarization of a relatively large group of neurons, almost always cortical neurons. But the cortical neurons can be in the neocortex, which is what we typically think of when we think of the grey matter in the cortex surrounding the surface of the brain. But it can also be the allocortex, including the archicortex, which, to note out for a moment, is phylogenetically older in terms of evolution. And it includes some of the deeper brain structures, which are still part of the cortex, as opposed to deep grey matter structures. And importantly, it includes the hippocampus, which is one of the main mesial temporal structures and is where a lot of focal seizures originate from. So, for seizures, for this inappropriate and excessively synchronous repetitive depolarization to occur, the brain environment needs to be such that there are excessive excitatory factors and insufficient inhibitory factors regarding neurotransmission, which is, of course, an electrochemical process. It's very tempting to think of the brain and of seizures as just electrical wires and electrical signals jumping around too quickly. But actually, transmission between neurons doesn't just happen at the speed of light with electricity jumping along axons and dendrites from one to another, because the signal needs to be transmitted from one neuron to the next across a synapse, and that's an electrochemical process which is dependent on neurotransmitters. So the overall neurotransmitter balance and the milieu of chemical factors in the brain is really important for seizure pathogenesis. And in particular, the failure of inhibitory factors is really relevant in the context of prolonged seizures and status epilepticus. Now, what is a seizure more from a clinical and electrographic perspective? Well, a seizure can be classified as being electroclinical, so that means it's both clinically apparent and there's an accompanying electroencephalogram EEG signal, which is ictal. Or it can be clinical only, so there are clinical manifestations, but the EEG is negative at the time. And of course, that can be the case. Not every true clinical epileptic seizure has an abnormal ictal EEG trace present at the time, especially in a surface EEG as opposed to an intracranial EEG. In order for a surface or a scalp EEG to pick up on electrocerebral discharges and seizures, it's often quoted that a minimum of 6 centimeters squared or up to 10 centimeters squared is required for the surface EEG to actually pick up that seizure. That number has been derived from cadaver-based studies, and it is debated a little bit as to what the exact number is. But suffice it to say that if you've got a very small area of cortex on the surface of the brain, that can cause a seizure, which can be surface EEG negative, or the EEG signal can be coming from a deeper part of the brain. And so by the time it gets to the surface of the brain, it's been so scattered and diluted that it's not visible. Or there could be superimposed artifact, which is preventing the surface EEG from picking up on the epileptiform ictal EEG traces. So just because an EEG, a surface EEG, is negative does not mean that an episode is not a seizure, because it can still be a clinical seizure. And then conversely, you can have electrographic seizures which are subclinical or clinically silent. So that's when someone has a clear seizure on an EEG that meets specific EEG criteria for a seizure, but with no clinical manifestations whatsoever, perhaps because it's in part of the brain that just isn't causing clinical symptoms, which are observable to an external person and they're not perceivable subjectively by the patient either. Or perhaps the patient is asleep at the time and it doesn't reach the threshold to wake the patient up or cause any subjective symptoms, and it's not observable either. Philosophically, I suppose there is also a possible fourth option of having a subclinical and an EEG negative seizure, but then by definition, no one could ever know that they existed at an epistemological level. So this is getting a bit reductive and a bit silly at this point, so we'll ignore that one for now. The EEG criteria for definitions of electroclinical and electrographic only seizures will be discussed in a later episode. And of course, that's a more advanced topic. Now, we've spoken about the clinical manifestations of seizures, but what are the clinical manifestations of seizures? Well, it depends. And it depends entirely on the regions of the brain which are involved and the underlying function normally of that area of brain and how it's been affected. As a really good rule of thumb, typically seizures produce positive symptoms, so positive sensory and motor phenomena. For example, paresthesias, positive special sensory phenomena like vision changes or funny smells, or motor phenomena that are positive, such as jerking movements, to use a non clinical term that a patient may describe. And this is in contrast to, for example, stroke, which typically produces what we call negative symptoms. So that would be hypoesthesia or anesthesia, or paresis or paralysis in the sensory and motor contexts, respectively. Although I did say that these are rules of thumb, and there are important exceptions to both of these. So seizures can still cause negative symptoms, and strokes can still cause positive symptoms. But if someone's symptoms on the whole are predominantly positive, that does strongly point more towards seizure or some other cause. Whereas if the symptoms are predominantly negative, then that more points towards stroke or some other cause. Now, it's important to note that what I've been talking about so far and what this episode talks about is the definitions and the classification of seizures. But importantly, epilepsy has a different set of definitions and classifications, which are very closely related, but they are different and they're a bit more complicated. And that will be the topic of the next episode, not the current episode. And it's also important to distinguish an unprovoked seizure from an acute symptomatic seizure in terms of making an epilepsy diagnosis, which will be discussed further in this episode and in the next episode. So, how do we clinically classify seizures? We've spoken about how they manifest, but how do we clinically classify them? Well, it's been nicely defined by the ILAE, which stands for the International League Against Epilepsy. And one of my colleagues joked that it sounds like a superhero gang, such as from an Avengers movie. The ILAE periodically updates their classification system, and many patients and doctors still use the older terminology. So, the most recent edition was the 2025 edition this year. Prior to that was 2017, and then there were older editions still. So it's important to be familiar with and, for the most part, or for the whole part, to use the most recent terminology. But you still do need to understand how that relates to the older terminology, because many patients and many other colleagues still use the older terms. So, how does the ILAE actually classify seizures? Here's a table. I did say in the introduction episode there weren't going to be too many tables, but this is one of them, but I've simplified it. I'll start with the 2025 classification, and then I'll compare it with the older classifications. So the 2025 classification divides seizures into three types: focal, generalized, and unknown in regards to the onset. Turning first to focal seizures, these are further subdivided into three forms: focal seizures with preserved consciousness, focal seizures with impaired consciousness, or focal to bilateral tonic-clonic seizures. There is an additional qualifier which is added to the first two of these, wherein a seizure either has observable manifestations or it is without observable manifestations. Secondly, in terms of generalized seizures, there are generalized tonic-clonic seizures, absence seizures, and other types of generalized seizures, which we'll discuss on the next slide. Finally, in regards to unknown onset, there are bilateral tonic-clonic seizures, when you don't know whether it was of focal onset or generalized onset. And there are epileptic spasms, again, when you don't know whether it was of focal onset or generalized onset. Now let's compare it with the older classification schemes. Firstly, in regards to the 2017 classification, you will notice that there's actually a one-to-one relationship between the categories defined then and the ones in 2025. They've just changed some of the words for very deliberate reasons, but there is, as I just said, a one-to-one relationship between each of the categories. So in 2017, they defined focal onset seizures as either focal onset seizures with maintained awareness, focal onset seizures with impaired awareness, or again, focal to bilateral tonic-clonic seizures. And for the first two, there's an additional qualifier of whether there are motor manifestations or without motor manifestations. The generalized onset category is essentially the same in regards to the basics as the 2025 classifications. And in regards to unknown onset, again, there's not a large difference there. One of the older classification schemas also had an essentially one-to-one relationship between the more modern systems, but using quite different words. So instead of using focal, preserved consciousness, maintained awareness, they're called simple partial seizures. And instead of calling focal impaired consciousness or impaired awareness seizures, they're called complex partial seizures. And instead of saying focal to bilateral tonic-clonic seizures, they're called secondarily generalized seizures. So even though there's a one-to-one relationship there, the terminology is very different and it's a little bit confusing because the words don't immediately tell you what we're talking about, and that contributed to a lot of confusion amongst patients and families and doctors alike. So that's why we don't like to use that terminology anymore. They did still use generalized tonic-clonic seizures and absence seizures and other groups of generalized seizures, however. But that wasn't the case in an even older system of ILA classification, and you've probably heard of the terms grand mal and petit mal. So grand mal referred to a generalized tonic-clonic seizure, and a petit mal referred essentially to an absence seizure. But lots of people use the terms grand mal to indiscriminately refer to any motor seizure which looks dramatic, or any bilateral tonic-clonic seizure, irrespective of whether it was focal or generalized onset. And lots of people use the word petit mal to refer to either an absence seizure or any form of focal seizure with impaired awareness or consciousness, and it gets really confusing and it's not helpful. So please don't use that terminology. And it's important to clarify what the patient means or what a colleague means when they use that terminology. So just looking at the subtle but meaningful differences that were made between 2025 and 2017. So what changes did they make in this year's edition? Firstly, they deliberately removed onset from the name. They changed awareness to consciousness and have defined consciousness as the combination of both awareness and responsiveness. They've used observable as their qualifier for focal seizures, as opposed to motor features, although this is largely for the purpose of clinical trials, and there is considerable overlap between the two. And they're really the main changes. I do just want to point out one thing that I only realized actually in the last 2 years, I would say, and this confused me for 8 years or more, is that a focal to bilateral tonic-clonic seizure trumps a focal preserved or a focal impaired consciousness seizure. So if someone has what looks like a focal impaired consciousness seizure with oral automatisms, behavioral and speech arrest, maybe some lateralizing features, and then that progresses into a bilateral tonic-clonic seizure, you don't call that a focal impaired consciousness seizure progressing to a focal to bilateral tonic-clonic seizure, that entire episode is just counted as a focal to bilateral tonic-clonic seizure. Now, I mentioned that generalized seizures are a bit more complex, and they are. So let's talk about them at more length. So there are generalized tonic-clonic seizures, which I've already spoken about. There are also variations on this. So there are myoclonic tonic-clonic seizures and absence to tonic-clonic seizures. Then there are absence seizures, which can be typical, atypical, or myoclonic. Then there are seizures with eyelid myoclonia, with or without an associated absence. And then there are tonic, atonic, clonic, myoclonic, negative myoclonic, myoclonic atonic, and epileptic spasms as other types of generalized onset seizures. This terminology can be a bit confusing, but if you understand what the movement phenomenologically refers to, then you can understand what this type of seizure is. And we'll discuss this at greater length in some of the movement disorders episodes. Importantly, many of these characteristics can also be seen in focal seizures, but as a key differentiating factor, in focal seizures, the components are usually present unilaterally, whereas in generalized seizures, the components are usually present bilaterally, although there can be exceptions in both cases. So the types of seizures which are characterized as generalized onset seizures, but with motor characteristics that can also very well be seen in focal seizures are tonic, atonic, clonic, myoclonic, negative myoclonic, and epileptic spasms. It's also really important to note, and a lot of people don't realize this, that with the exception of generalized tonic-clonic seizures, all of these other types of generalized onset seizures are essentially really only seen in specific pediatric epilepsy syndromes, which may well then continue on into adulthood. But if you're seeing an adult in middle age, old age, who's presenting with new onset seizures, new onset epilepsy, and they don't have any history of epilepsy or seizures in childhood or in adolescence, then it is almost certainly either a focal seizure, or if it's a generalized seizure, then a generalized tonic-clonic seizure. It's almost never going to be one of these other generalized onset types of seizures, such as an atonic seizure or a clonic seizure. The pediatric syndromes that these are classically seen in are a number of syndromes such as Lennox-Gastaut syndrome and Dravet syndrome, which fall into the group of developmental and epileptic encephalopathies, or DEEs, which we'll talk about in an episode coming up shortly. Now, it does beg the question, and we're going to get a little bit philosophical here. Did the ILAE fundamentally change the seizure classification system in the most recent update? I would argue no, they didn't fundamentally change it because there is still a one-to-one conversion between all of the seizure types and qualifiers, but they did make subtle changes to the terminology. This then begs the question, were the terminological changes made beneficial or not? I would argue that it's not so straightforward. I think that the removal of the word onset was actually a mistake. I believe that their rationale is that we can't be sure that generalized onset seizures truly start in bilateral hemispheres or in essentially the whole brain simultaneously. And in fact, philosophically, this sounds really implausible. Even if someone had a sodium of 95 millimoles per liter, what are the chances that every neuron in the brain or every neuron in both of the frontal lobes is immediately going to begin firing in an excessively synchronized way at the same nanosecond? It seems completely implausible. However, when we say generalized seizure, we're essentially saying that to the best of our ability to tell clinically and electrographically, the seizure at least seems to us to start bilaterally or everywhere at once. However, we do know from intracranial EEG studies, especially stereo EEG with depth electrodes, that some seizures that look generalized on surface EEG or that look generalized clinically may actually start unilaterally and then propagate bilaterally very rapidly in less than a second, sometimes in a split second, mere milliseconds. So, philosophically, it ultimately must just come down to the temporal resolution and the accuracy of your measuring equipment in terms of how accurately can you measure time. What if we could record time by the nanoseconds? Would there be no such thing as a generalized onset seizure? Is every seizure actually a focal onset seizure? It is also important to recognize that generalized onset seizures have also been defined by the ILAE, I believe, as beginning within and rapidly progressing throughout and engaging bilaterally distributed networks, which may be quite an honest description actually, although it does then create a slippery slope. How rapidly does this propagation or engagement of these bilaterally distributed networks does the seizure need to travel in order for it to be called generalized rather than focal? And I do think it quite strongly supports the idea voiced earlier that perhaps all seizures ultimately are of a focal onset. And when we distinguish between a focal or a generalized onset seizure, we're really just commenting on the temporal resolution that we have and our ability to actually see whether it begins focally or whether we can't see that and it just looks like it begins bilaterally or generally. However, and this is important to stress that there have been some philosophical musings that we've just enjoyed. However, ultimately, the distinction between a focal onset and a generalized onset seizure is absolutely essential clinically. And this is because focal onset seizures and generalized onset seizures have very, very different etiologies a lot of the time, and they're also treated differently. So, yes, there are some anti-seizure medications which are broad spectrum and can be used to treat both generalized and focal onset seizures. However, there are some anti-seizure medications which are only used for specific forms of generalized onset seizures, such as ethosuximide. And there are a lot of anti-seizure medications which are really only used to treat focal onset seizures, carbamazepine being a reasonably good example of that. And even for the broad spectrum anti-seizure medications that cover both generalized and focal onset seizures, a lot of the time, some of those medications, such as valproate, are much better suited at treating generalized onset seizures and may be less specific for and less well tolerated than a number of the other anti-seizure medications which are available for treating focal onset seizures. So I don't think that removal of the word onset helps very much ultimately. One of the other major changes has been replacing the word awareness with consciousness. And the ILAE has defined consciousness as being the set denoting both awareness and responsiveness. So consciousness equals awareness plus responsiveness. So what was the rationale of the ILAE? Based on my best understanding, the idea is that responsiveness is very important clinically. So just think how important someone's responsiveness during a seizure is in regards to safety or lack thereof when driving or swimming or operating heavy machinery or working at heights. And also responsiveness is easier for an external observer to objectively assess. Awareness is best assessed by the patient himself or herself, and the patient may be amnestic or otherwise unable to comment on their awareness either at the time or after the fact. It can also be very difficult to distinguish between impaired awareness and impaired responsiveness in reality, because an external observer on an epistemological basis can arguably really only truly assess responsiveness if that's considered to include the patient talking and communicating to us. And conversely, really only the patient knows what their own internal state of awareness is like or what it feels like. And I'll bring in some philosophy here just because what's the point in doing a philosophy degree if you can't refer to it? You probably haven't heard of a philosopher called Thomas Nagel, and he was a famous metaphysician working in philosophy of mind. And he wrote a very famous paper called What Is It Like to Be a Bat? And he argued that we can guess what it's like to be a bat. We can describe what it must be like. But unless you're a bat, you can't know what it's like to be a bat. And there's this concept of qualia, or someone's internal subjective experience of what it's like to be that person. And unless you're that person, then arguably at least, or many have reason that you can never really know what it's like to be in their shoes. However, someone's awareness is also important clinically. It's not just responsiveness that matters. So, my understanding is that the ILAE wanted to incorporate both awareness and responsiveness into their classification system. So, they've done this by changing awareness to consciousness and defining consciousness as the combination of both awareness and responsiveness. So, has it worked? Well, I think there are some problems with their strategy. Firstly, consciousness probably doesn't simply just equal the sum of awareness and responsiveness. Doctors and philosophers have struggled to define consciousness for centuries or even millennia, especially in the case of the philosophers. And there's a whole branch of philosophy called philosophy of mind, as I just referenced, dedicated to the study of this single question. And arguably, at least in some circumstances, responsiveness doesn't actually have anything to do with consciousness at all. So consider a patient in a locked-in state, a classic example of which would be a patient who suffered a pontine intracerebral hemorrhage. So that means that it has affected the descending motor tracts, but it hasn't affected the reticular activating system, which is located more rostrally in the midbrain, so the top part of the brainstem. So the patient is still conscious and alert and aware, but they are completely paralyzed bilaterally. So a patient who is locked in from a pontine intracerebral hemorrhage may be able to do vertical eye movements only, because the nuclei for the cranial nerves that control vertical eye movements come off the midbrain, not off the pons. But all of the corticobulbar tracts lower than those cranial nerves, and all of the corticospinal tracts controlling the arms and the legs, are completely severed or dysfunctional. So the patient can't move and they can't communicate otherwise. And you can easily imagine how a patient who can only control vertical eye movements could be mistaken as being unconscious and unresponsive when actually they're not at all. And they might be completely awake and alert and feel everything and be able to think, but they're just trapped and paralyzed. This problem could be circumvented by saying, in the context of epilepsy, that impaired consciousness requires other causes of reduced responsiveness to have been excluded first, however. And then one lesser point, but worth making, is that there is a distinction that can be drawn between the level of consciousness and the content of consciousness. And both of these can be affected or impaired. Intuitively, when we think about consciousness or impaired consciousness, we're thinking about the level of consciousness. And this is in medicine and in neurology and in epilepsy in particular. So thinking about terms in regards to reduced Glasgow Coma Scale, GCS, or drowsiness, obtunded, stuporous, comatose. Although the content of consciousness can also be impaired in a seizure. So there could be a subjective sensory phenomena, which is therefore adding to or in some way affecting or altering the content of someone's conscious experience. Similarly, other psychic phenomena, and also memory and other cognitive faculties that could be impaired, but which are not directly related to the level of consciousness, which can also really blur the lines as to what is being referred to when we say someone has impaired consciousness, and regarding what is clinically significant regarding safety and prioritizing of management goals in regards to the aggressiveness of anti-seizure medications. Memory in particular is an interesting one because many would argue that memory actually is closely related to someone's consciousness or their identity, and others might not. And someone's memory is important in many activities which could be unsafe with lack of memory. So if you were driving and you can't remember where you're going, or you can't remember how to drive, then that's going to be a problem. So overall, there are pros and cons of either approach, so using consciousness or using the older term awareness. I don't think that consciousness is a clear winner overall. And I think ultimately we need to appreciate that consciousness is supposed to be being used to refer to the sum of awareness and responsiveness. So when you're assessing whether someone's focal seizure is with impaired or preserved consciousness, you need to think, is the patient aware and is the patient responsive? Another change was the change in using the term observable manifestations as opposed to motor manifestations. I think their rationale for this one was largely for standardizing clinical epilepsy research, especially in regards to defining seizures as being countable by an observer, which is essential for determining eligibility for clinical trial enrollment, and then measuring seizure frequency as a central outcome measure. Realistically, many observable manifestations in practice are motor manifestations anyway, but there are some important exceptions. Some cognitive and language phenomena, for example, dysphasia, confusion, disorientation, apraxia, neglect, may be very obvious and observable to a second party, but not be motor phenomena. And the same can be said for some autonomic phenomena, such as cutaneous or thermoregulatory flushing, piloerection, diaphoresis, gastrointestinal symptoms such as borborygmi, flatulence, siluria, pupillary changes, respiratory changes, genitourinary changes such as incontinence, or affective emotional phenomena such as outward displays of anger or even hypersexuality. Although of note, some phenomena, such as purely sensory phenomena, that is, somatosensory or special sensory, or a completely indescribable aura that the patient just cannot put into words and cannot offer any further elaboration on, are by definition always non observable. I do think that this change is a clear improvement for the purpose of clinical trials. In daily clinical practice, there's not a huge difference if the symptoms that were going to be described as observable were motor symptoms anyway. And you do still ultimately need to clarify whether they're motor, sensory, cognitive, language, autonomic, affective, regardless. But it is an improvement. I'm not going to go over this table, but it's just to show you that there is really quite a large range of symptoms and phenomena which can be experienced by the patient during a seizure, some of which can be observable, some of which can be non-observable, and some of which it just depends on the context. So the overall categories, without going into the details, are elementary motor phenomena, complex motor phenomena, sensory phenomena, cognitive and language phenomena, autonomic phenomena, affective or emotional phenomena, and an indescribable aura. Now, this I think is important to draw attention to. One personal point of confusion that I had for a decade and really only got to the bottom of recently was how should a hypermotor or hyperkinetic seizure, which is typical of sleep-related hypermotor epilepsy, or formerly known as nocturnal frontal lobe epilepsy, be classified? I previously thought and had previously been taught that these were classified as focal to bilateral tonic-clonic seizures. However, I now have learnt that that's incorrect and they're actually classified as focal impaired consciousness seizures. Why? Well, focal to bilateral tonic-clonic seizures do not account for any focal onset progressing to bilateral seizure that has some form of bilateral motor activity. This is because there are many focal seizures which may progress to involve bilateral hemispheres and cause complex symptoms, maybe focal impaired consciousness seizures, but they don't cause a bilateral tonic-clonic seizure. And the word hyperkinetic or hypermotor in the epilepsy context is used a bit differently to the way that it's used in the movement disorders context. So in movement disorders, or if you were to open up the dictionary, you would think that hyperkinetic just meant an excess of movement, irrespective of what that movement is. And hypokinetic or hypomotor just means the opposite. So we think of chorea or athetosis or Huntington's disease as being a hyperkinetic or hypermotor movement disorder. And we think of Parkinson's disease as being a hypomotor or a hypokinetic movement disorder. But in epilepsy, things are a bit different. The word hyperkinetic is not this catch-all umbrella phrase, but instead it refers specifically to these typical, bizarre, complex, integrated, coordinated movements. For example, alternating bicycling leg movements, which are typical of sleep-related hypermotor epilepsy, for example, as opposed to just any increase in any form of motor activity. Conversely, a focal to bilateral tonic-clonic seizure really does refer to a focal onset seizure, which then progresses across to both hemispheres and then results in a classic bilateral tonic-clonic seizure. And so if you were to walk in the room halfway through the seizure, just as it was becoming a bilateral tonic-clonic seizure and you hadn't seen the beginning of the seizure, there is no real way that you could tell whether it was a generalized onset tonic-clonic seizure or a focal to bilateral tonic-clonic seizure, unless there were subtle lateralizing asymmetries in the tonic or clonic component. I do think that this does still have some flaws, as in focal to bilateral tonic-clonic seizures, the tonic phase is often very minor or barely existent. And practically speaking, if a patient has an obvious seizure that begins focally and then it evolves into bilateral clonic movements, they're often still labeled as a bilateral tonic-clonic seizure. Maybe they shouldn't be, but in practice that often happens. And there's no stated diagnosis of a focal to bilateral clonic seizure without the second T in there. So, after that long discussion about terminology, which terminology should I use? Which terminology should you use? Well, the most recent terminology should be used. It's just going to be confusing if people use old terminology. And there was a very large working group that went to a lot of thought and effort to develop these classification schema. But if you do use some of the older terminology from the 2017 classification, such as terms like aware seizure, impaired awareness seizure, motor or non-motor qualifiers, I honestly think this is completely acceptable. And I deliberately still use the word onset in terms of focal onset and generalized onset. I do not think that the terms simple partial seizure, complex partial seizure, secondarily generalized seizure, or grand mal or petite mal seizure should be used, even though they're easier to say and they have fewer syllables in them. But you do need to know what they can or may refer to, because many patients and colleagues will still use these terms. So, what are my three main bugbears when it comes to seizure classification? Well, firstly, it's when colleagues say the patient had a seizure when it's really not clear whether what the patient had was even a seizure or not. If you're not sure, it's much better to say that the patient had an episode or a loss of consciousness or a period of reduced level of consciousness, and then to just describe in detail what actually happened or what was witnessed. And then it's much easier for the person on the other side of the phone or on the other end of the conversation to try and determine, was it a seizure or was it not a seizure? We'll talk about the distinction between seizures and seizure mimics in an upcoming episode. My second bugbear is colleagues saying that a patient had a generalized tonic-clonic seizure when it's really not clear whether it was a bilateral tonic-clonic seizure at all, let alone whether it was a generalized onset tonic-clonic seizure or whether it was a focal onset to bilateral tonic-clonic seizure. Again, if you're not sure, it is much better to just describe what happened or what was witnessed. And we'll get onto this again in one of the following episodes on seizure semiology. Finally, my last bugbear on this matter is colleagues calling an episode of behavioral and speech arrest an absence when it was really actually a focal impaired consciousness seizure. Yet again, if you're not sure, or even if you think you're sure, it's much better to just describe what happened or what was witnessed if it's an adult patient without a history of a pediatric generalized epilepsy syndrome. Then it's almost certainly a focal impaired consciousness seizure rather than an absence seizure, unless the patient actually did have absence seizures as a child and as an adolescent and they were just never diagnosed. Or maybe the episode wasn't a seizure at all. Adult onset idiopathic generalized epilepsy with absences is uncommon, not completely unheard of, but uncommon. And acute symptomatic seizures resulting in absence seizures are practically unheard of. These 3 points are really important because they really do lead to misdiagnosis and mistreatment. For example, treating someone that didn't actually have a seizure to begin with an anti-seizure medication, or treating a focal seizure as a generalized seizure with inappropriate anti-seizure medications, and vice versa. Now, there's this other important distinction that I alluded to earlier in terms of seizures, and that is unprovoked versus provoked or acute symptomatic seizures. This is essential for determining whether the patient has epilepsy, which we'll talk about in the next episode, and it's generally, therefore, really important in determining whether the patient requires anti-seizure medication or not. What is an unprovoked seizure? An unprovoked seizure is one which is not caused in the context of an acute provoking factor, and it therefore implies that there is an underlying predisposition to have future unprovoked seizures, and that risk is above and beyond the general public's baseline risk of having a seizure. Importantly, classic triggers for a patient who has a diagnosis of epilepsy in having their seizures do not count as provoking factors. And sleep deprivation in particular does not count as a provoking factor in this context, unless perhaps if it's absolutely extreme sleep deprivation. So someone deliberately forcing themselves to stay awake for 72 hours straight for whatever reason. I remember that some friends of mine foolishly decided to attempt to do this at a high school camp that I went to. Now, this is in contrast to a provoked seizure or an acute symptomatic seizure. And the way to think about this is it's a seizure which is caused by an acute provoking factor, in that you would not be surprised if a person without an increased predisposition to seizures would have still had a seizure in this context. And everyone has a seizure threshold. Everyone can have a seizure. If you drop someone's sodium low enough or you withdraw someone from alcohol enough, everyone is capable of having a seizure. So the classic examples, some of which I've just mentioned, are alcohol withdrawal, cocaine intoxication, severe hyponatremia, intracranial hemorrhages, less commonly but sometimes acute ischemic strokes. Importantly, the seizure needs to occur within 7 days of the insult by definition. Although note, this is somewhat arbitrary. If a seizure happens 6 days after a intracerebral hemorrhagic stroke versus 8 days after the stroke, does that really carry a significant distinction? There is some significant grey area here. So importantly, when the insult is acute but it's present and ongoing. And this is especially true in tumor-related seizures and tumor-related epilepsy. And as I understand it, that's generally not considered an acute symptomatic seizure, but it can be tricky. What if someone presents with a seizure and that's what leads to the diagnosis of a brain cancer or a brain tumor of some other form? Presumably, that structural lesion has been present for more than 7 days, but it's been diagnosed in less than 7 days, and then it may be an ongoing persistent problem, or maybe it's treated with surgery, radiotherapy, chemotherapy, other forms of systemic therapy, but then there's likely to be some residual encephalomalacia, which is still going to be an epileptiform lesion moving forward. So, is tumor-related seizures in the acute phase a provoked or an unprovoked seizure? That's tricky, but would usually be thought that it's not acute and that it's an ongoing problem. Another reason that the distinction is somewhat tricky is that patients with acute symptomatic seizures often do actually have an increased risk of having future seizures compared with the general population. So just because someone's had an alcohol withdrawal seizure doesn't mean that they're not at an increased risk of having other types of seizures in the future compared with the baseline populations. If you think about it, if you have 10 people in a room that are all in intense alcohol withdrawal and one or two of those people have a seizure and the other 8 don't have a seizure, why is it that 2 of those people had an alcohol withdrawal seizure and the other 8 people didn't? There is some difference between those patients. There's one older term which is worth mentioning here as well. You may occasionally hear the term a remote symptomatic seizure, which is basically a seizure in the context of some brain problem, such as a remote brain insult or an underlying genetic condition, and the seizures or the epilepsy are thought to be symptomatic of that underlying insult or that underlying brain problem. But it's a historic or an old or a down the track problem, not an acute problem, although this terminology isn't frequently used today. It's also important to note that pediatric febrile convulsions are essentially a type of acute symptomatic seizure, although they are generally considered as just being completely separate altogether in their own category for both clinical and epidemiological purposes. Based on my understanding, although I am an adult neurologist and epileptologist, not a pediatric neurologist and epileptologist. Let's briefly talk about reflex seizures now. So, reflex seizures are recurrent seizures which are reliably produced by the same trigger, which would usually be completely benign in someone without an associated reflex epilepsy. And this is considered discrete from a provoked seizure. There is always an associated epilepsy by definition to reflex seizures because they are recurrent. There is a few defined types of reflex seizures and reflex epilepsies, specifically photosensitive epilepsies and seizures, reading, musicogenic, thinking, eating, hot water, sexual and orgasm, movement or praxis induced, and somatosensory induced as the big players. So the important distinction here is that only a person with reading epilepsy will have a seizure provoked by reading, whereas most people on the planet can read and not have a seizure. Whereas an acute symptomatic seizure or a provoked seizure is a seizure in the context of, for example, severe hyponatremia or marked alcohol withdrawal, where most people on the planet would have a seizure if they were in that extreme state of stress. So, you may have noticed that some of the words used in terms of factors that are contributing to seizures are used quite specifically and have important distinctions. So, let's revise them quickly. Precipitating factors pertain to unprovoked seizures. So, that's a person who has epilepsy and then something happens, such as they had a bit of sleep deprivation, or they missed their anti-seizure medications, or they were a bit stressed, and they are factors that then brought on a seizure in that patient with epilepsy, but those factors would not normally cause a seizure in someone who doesn't have epilepsy. Conversely, there are provoking factors which cause provoked seizures or acute symptomatic seizures. For example, having a sodium of 100 millimoles per liter, cocaine intoxication, alcohol withdrawal, a hemorrhagic stroke, all in the last 7 days. And they are factors that could cause a seizure in practically anyone. Finally, there are triggers, although that word is used a little bit less specifically, but I'm using it here to refer to reflex triggers for reflex seizures and reflex epilepsies, such as listening to music or reading or flashing lights, that really only brings on a seizure in a person that has that specific reflex epilepsy syndrome. While we're talking about important terminological distinctions here, there's one other important distinction between a premonition and an aura. So, what's a premonition? A premonition is a vague feeling that a seizure may be coming on in the next few hours or the next day or so. And this is pretty common in patients with both focal and generalized epilepsies, and it does not count as the focal onset of a seizure. So it can still be present in a patient who is having generalized onset seizures and has a generalized epilepsy syndrome. I'm not sure what the cause of this premonition is. I could speculate that it may be due to general changes in the biochemical milieu of the cerebrum, or possibly circadian or chronotropic factors. Contrast that with an aura, which is the actual symptomatic onset of a focal seizure. The aura is the seizure. It is the beginning of the seizure. So it has to be focal onset, and it has to be a focal onset seizure. You cannot have an aura with a generalized onset seizure because by definition, if there's an aura, that is the focal onset. But the aura lasts for seconds or minutes. It doesn't last for hours or days like a premonition can. The last slide is the definition of status epilepticus, which is obviously important when we're defining and classifying seizures. So status epilepticus is defined clinically and electrographically, and broadly speaking, it's divided into convulsive status epilepticus and non-convulsive status epilepticus. Convulsive status epilepticus is then divided into generalized status epilepticus, which is convulsive. So that's basically someone having a bilateral tonic-clonic seizure, irrespective of whether it's of generalized onset, focal onset, or unknown onset. And it's clinically defined as a bilateral tonic-clonic seizure, which is lasting for 5 minutes or longer, or 2 bilateral tonic-clonic seizures in short succession without resolution to a normal mental state and neurologic baseline in between the 2 seizures. The reason for that is it is implied that the lack of neurologic resolution in between is either an aggressive cluster of seizures with a short postictal period in between, or the period in between might not be postictal at all. It might actually be an ictal period electrographically, and the whole thing is just one prolonged seizure. So just to reiterate, because this is very important, generalized convulsive status epilepticus is a bilateral tonic-clonic seizure, either of generalized, focal, or unknown onset, which lasts for 5 minutes or more, or 2 bilateral tonic-clonic seizures in short succession without resolution to a normal mental state and neurologic baseline in between. Status epilepticus of the generalized convulsive nature, as you probably know, is a medical emergency and can be fatal, and treatment will be discussed in a later episode. The other form of, technically speaking, convulsive status epilepticus can be focal motor status epilepticus. This is almost synonymous with epilepsia partialis continua, or EPC, and some people may use it interchangeably. Some other people may draw a bit of a distinction between the two, but we won't go into that here. So that's someone who, for example, may be having a focal motor seizure just causing continuous repeated right upper limb clonus. Or one really memorable case in my mind is a patient who had non-small cell lung carcinoma with a brain metastasis. Which side was it on? It was on the right. It was on the right, and it was on or near the precentral gyrus in the frontal lobe. And the patient, as a result, had consistent left hemifacial clonus, but interestingly, they also had right forehead clonus. And that's because if you think about the opposite, it's kind of like the opposite of Bell's palsy, right? So the forehead has bilateral innervation at an upper motor neuron level, whereas the mid and lower face has unilateral representation from an upper motor neuron level. So when you have a patient who has a stroke, they have an upper motor neuron facial palsy. So they classically have middle and lower facial paralysis, but they may have forehead sparing, although that's not always the case. Whereas if you have a patient who has a lower motor neuron facial lesion or a facial palsy, such as in Bell's palsy, because you're knocking out the lower motor neuron ipsilaterally, that's going to be affecting the upper, the middle, and the lower face. But that's in terms of negative symptoms. And in our patient, it was the opposite. It was positive symptoms. So even though it was a right-sided frontal lesion, that is then having representation in the left midface and the left lower face in terms of the lower motor neuron, but it's also being represented in the left forehead and the right forehead because of the bilateral upper motor neuron representation to both the left forehead and the right forehead. So this patient, who unfortunately had metastatic lung cancer, had this constant left hemifacial and right forehead twitching, which was time locked with the epileptic discharges seen on the EEG. So that was focal motor status epilepticus, and a classic case of EPC, epilepsia partialis continua. I might tell you a bit about the treatment and the outcome of that patient in another episode. Now, the other type of status epilepticus is non-convulsive status epilepticus. This mandates an EEG in order to make the diagnosis. And there are specialized EEG criteria, such as the Salzburg criteria or the closely related critical care EEG criteria, which will also be discussed in a later episode and are a bit too advanced for this episode. But it's important to know that it requires a longer time duration in order to make the diagnosis. And I've just changed the text on the slide because there was a typo. It's surprisingly common in intensive care unit environments. Non-convulsive status epilepticus is a serious medical urgency, but it's not a complete emergency in terms of urgent treatment in the same way that convulsive motor status epilepticus is. The thing to beware here, though, is that you can have minimally convulsive or burnt out convulsive status epilepticus, which is really a form of late stage convulsive status epilepticus, but it can mimic non-convulsive status epilepticus, and it can therefore have a very, very guarded prognosis and a high mortality, especially if it's misdiagnosed and poorly managed. So if you come across a patient and they seem obtunded and you wonder about non-convulsive status epilepticus, you've got to look really, really, really closely for any subtle motor features and get a close history from any witnesses who might have seen what happened an hour ago or 2 hours ago, because it's possible that this patient was actually in convulsive status epilepticus and they're still in convulsive status epilepticus, but they're just at that burnt out late pre-death stage. And you don't want to misdiagnose that as non-convulsive status epilepticus and take your time, because that is a hardcore medical emergency that requires immediate treatment. So you need to look for subtle motor features and take a careful history. So that's all for today's episode. Thank you so much for tuning in. There will be upcoming closely related episodes on the definition and classification of epilepsy as opposed to seizures, distinguishing seizures from seizure mimics, and on seizure semiology, localization, and lateralization for the purpose of distinguishing focal from generalized onset seizures. So please don't forget to like, comment, and subscribe. Visit our website, rneurologyeducation.org. That's R as in the letter R, for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms. The address for all of this is R Neurology Education, with the exception of X, formerly Twitter, which is R Neuroeducation. And please email us on contact@rneurologyeducation.org for any questions or queries, and to subscribe for updates on future content. From Cortex to Curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.